Okay, we can get started now. I'd like to welcome everybody to the Musella Foundation's Brain Tumor Awareness Month webinar series. Tonight's special guest is Dr. Dan Orringer from NYU Langone Health. He's a neurosurgeon. The topic today is new technologies to take the guesswork out of brain tumor surgery. Take it. Go ahead.
Thanks a lot, Al. Thank you so much for having me. It's a pleasure to be here in this forum, and I just wanted to thank the Musella Foundation for the opportunity and all the great work that you do on behalf of the brain tumor community. So, as you mentioned, I'm an associate professor of neurosurgery and pathology at NYU, and my passion is in developing ways to do better brain tumor operations, and my clinical practices and my research practice is focused exclusively on the care of brain tumor patients, especially gliomas and metastases. Disclosures, I'm going to talk about a couple of technologies today, and I'm affiliated with some of the companies that develop these technologies and distribute them, so these are notable. So I'll start in our operating room, and I love this picture. It's a recent picture from our operating room at NYU, and I like it because it shows the centrality of technology and data in our brain tumor operating room. And we have a navigation system, we have a 3D visualization system, we have our patients' vital signs, we have ultrasonic data, just to name a few in this picture. And we're integrating all those different types of information to make good decisions during brain tumor surgery. And that's really what this talk is going to be about today. This all originates from a challenge we have in the operating room. Here we can see the surface of the brain that we're operating on. And really, this kind of stretches back for me in a very personal way. And I can remember very clearly the first time I saw a brain tumor operation and had this wonder about how the surgeons were differentiating tumor from normal brain in this patient who happened to be 7 years old. And I just thought it was fascinating to see their decision-making and try to understand what they were seeing and how they were getting the tumor out. And I realized at that time it was really difficult to differentiate tumor from normal brain. And that didn't sit well with me. And it kind of put it in the back of my head. It prompted me to go into neurosurgery and ultimately prompted me to focus my entire clinical and research practice around figuring out better ways to take out brain tumors more completely and more safely. So to take a step back even further to give some context for the presentation. So there are three general ways that we treat brain tumors today. Number one, chemotherapy. Number two, surgery. And number three, radiation therapy. None of these in isolation works well on their own, but all three of them work together to provide the best shot that we have. There's sort of a fourth prong that we don't show here in immunotherapy, and I know that's the topic of an upcoming webinar. And it's an emerging area in our field. There's been a lot of hope generated in other fields of cancer related to immunotherapy, but for now, that's experimental. So what we're left with is these three things: surgery, chemotherapy, and radiation. As a surgeon, my focus has been on developing ways to do surgery as well as we possibly can. And it's notable, too, that the intervention that we have that makes the biggest difference, the biggest impact on the duration of survival for our patients is the quality of the surgical intervention they get. And so surgery is the cornerstone of the treatment of brain tumors at this point, and it's really important in dictating how the patient is going to do over time. And drilling down on that a little bit more, why is that the case? Why do we operate on brain tumors? Why is it so important to us? Why is it so important to getting the best outcome that we possibly can for our patients? There's sort of a couple of main things. First of all, as you can see in this image, I don't know if you can see my cursor, but the brain tumor here lights up as bright. And the rest of the brain tissue is a bit more dull. What you see here is a massively dilated region of the brain that we call a gyrus. And the tumor is compressing various areas of the brain. In this case, it was causing seizures, and it was causing weakness on the side of the body opposite this tumor, which in this case happens to be on the right side. And in this patient, it was clear that we needed to relieve the mass effect being caused by the tumor. But the other important reasons, as I mentioned before, is that we're not doing surgery in isolation. And we know that when we take a tumor like this out, we know that the chemotherapy and radiation are going to be more effective afterwards. In addition, taking out a tumor like this decreases the likelihood of seizures and decreases the incidence of neurologic deficits. And more importantly than anything else, we know that the more tumor we take out, the longer the patient will live. Probably the most central reason that we take out tumors like that is to improve a patient's quality of life. This is a picture of Mark Brush and his family. Mark is the one in the hat, and he was a patient of mine who died of a glioblastoma. And I put him in here because he's someone who we were really able to move the needle on through surgery. Essentially, he had a tumor in a very important area of his brain. Given our surgical intervention, we were able to prolong his life and give him a relatively normal quality of life for many, many months leading up to his ultimate decline and demise. And so probably the most important reason that we do this is to improve the quality of life of our patients. There's a lot of data, and I put one curve in from an important paper in our field to show that for every, I mean, it's not down to the granular level of the cell, but for every percentage of the tumor we can take out, patients generally tend to live longer. And this is part of a trend that exists, such that the more tumor we take out, the longer patients live. And that's what we're seeing with this curve here. The question is then, how often, number one, how often are we able to achieve optimal results in our brain tumor patients? That was something that sort of bothered me when I was watching that first brain tumor operation I alluded to. Namely, it seemed like the surgeons were kind of guessing where the margins were. And I saw this more and more as I progressed in my training as a neurosurgeon, ultimately to the point where in my last year of my training, I felt like I really needed to quantify this. And what I wanted to do was to try to figure out how often are patients getting the brain tumor operation that they should be? And specifically in patients in whom tumors can be removed fully, how often are patients actually getting that result? And this was a retrospective study that I completed at the University of Michigan. And we looked at a series of patients in the study and identified 17 of them in whom 3 of our neurosurgeons felt that complete removal of the tumor would not be associated with any adverse neurologic consequence. And amongst those 17 patients, only 4 of them got complete resection based on the postoperative MRI. So to put that into context, if you generalize that, then a large fraction, maybe a third of brain tumor patients could undergo complete resection of their tumors. And probably only 20% of those patients are actually getting the entire tumor removed in the top brain tumor centers with the highest volume. And I think this statistic is a bit out of date. You'll see the references to 2012, and I think things are better now at the centers that are the best resourced. But it goes to show that I think these results are probably what you would still see at most centers that take care of brain tumor patients. Without technologic adjuncts that have emerged in our field and really the state-of-the-art technology, there's a really good chance that a patient is not going to get the brain tumor operation that they should, and that tumor tissue will be left behind. And those patients are at a disadvantage for all of the reasons I mentioned earlier about why brain tumor surgery is so important in quality of life, in survivorship, in the response to radiation and chemotherapy. So I think this data frames the problem pretty nicely. And the question is, why don't we achieve our ideal result in the operating room more commonly? And for one, even the best brain tumor surgeons will acknowledge that one of the problems is that we really have trouble delineating tumor from normal brain. And this tumor that shows up really well on an MRI is virtually indistinguishable when we take this patient to the operating room. It's really hard to be able to see where the tumor is, and the surgeons struggle because of that. And tumor is left behind because it essentially is camouflaged. In addition, tumor spreads into normal brain in a diffuse way, and especially with tumors of the brain, what we can see here is a microscopic view of how tumor spreads into the brain. There are some areas of this image where the cells, these dark spheres, are relatively tightly packed, and there are other areas where they're not. But it would be pretty hard to draw a line between where the tumor ends and the normal brain begins because these tumors infiltrate. And that's just the nature of gliomas and all tumors in the brain, even tumors that are extrinsic to the brain, like tumors that spread from elsewhere in the body, like metastases, or tumors that come from the coverings of the brain, meningioma, can infiltrate into the brain to some degree. And so necessarily, we're working on a macroscopic scale. We're working mainly on what our eyes can see, what our operating microscope can see traditionally. And so being able to judge what's happening on a microscopic scale with just macroscopic data means that necessarily there will be some cells that are left behind. That goes along the lines of tumor visualization, and I include this picture. I appreciate some of these images are a bit graphic, but this is what we see. And we're looking in the cavity of a brain tumor that I took out back when I was in practice a couple of years ago. And we're looking into the resection cavity, the place where there was tumor. And what you see in the center is rather difficult, a rather difficult challenge for us. We see this tissue that looks like brain, and it's really difficult to be able to ascertain where the tumor is and where that normal brain is. And when we sample this cavity and send tissues to look at under the microscope, we note that some areas that look normal contain tumor, some areas that look normal have no tumor, and there's every shade of gray in between. And so being able to try to approximate that difference amongst the tissue, the tumor content of the tissue can be a real challenge for us. Sometimes tumors are hard to get to, and I won't talk about the technical aspects of that, but you can imagine that a deep-seated tumor like this, where we can see the bright enhancing tissue that's in the center of the patient's brain, can be difficult to access. There are other reasons that we fail too, and as physicians, our primary goal is to do no harm, and so we err on the side of leaving tissue behind when we are concerned that it may cause damage to our patient. And for that reason, the default, and this is quite reasonable for most surgeons, would be to leave tissue behind if there's some question. What that also means is that tumor is left behind. And there is some reason that it makes us all uncomfortable as brain tumor surgeons, because we know that in a lot of cases, because surgeons want to stay safe, there's tumor that could be left behind tumor that's left behind that could come out. So that was sort of the rationale for the techniques and technology I wanted to share with you, and to make sure that the brain tumor community is aware of what's out there that will allow us as surgeons to provide you with the best surgical outcome. And it's really important for patients to understand what these technologies are so you can ask well-informed questions, and you can ensure that the surgeons who are operating know that you're educated and are, expect the state-of-the-art technology which is out there to prolong your life, to prolong the life of your loved ones, and to make sure that you're getting the best possible results down the line. So one of the most central technologies that we have is actually also one of the most low-cost technologies. And there are two elements to ensuring that we get out as much tumor as possible. One is seeing the actual tumor, and the other is sort of seeing the function of the brain around the tumor. Above all, we are aiming to do the safest possible operation. And the first consideration to achieving that goal is making sure that we understand where the areas are in the brain that we can't operate. And as I mentioned, there were a third of those patients in my original paper where complete removal of the tumor was feasible. In the other 2/3, the raters that were in that study felt that there was substantial risk associated with taking the tumor out. And what our mapping of the brain allows us to do is to determine positively whether a certain area of the brain is safe to take out or not. So mapping is really important. What this refers to is using electricity to determine the various regions of the brain that have specific functions. And if we identify a portion of the brain that is very important for movement of the hand, for example, or language, for example, we know that that's an area that can't be removed at the time of surgery. And so we have to be careful above all else, more important than getting the tumor out, preserving the function in that area. So mapping is essential. Image guidance allows us to take MRI data that we acquire before surgery and bring that into the operating room and represent that in 3 dimensions. And this tool that we call stereotactic navigation is ubiquitous and certainly is present in all centers that do brain tumor surgery, and is essential in allowing us to understand exactly where we are in the brain when we're operating. Unfortunately, it doesn't allow us to maximize how much tissue we're taking out because this modality is based on a preoperative image and everything changes when we open the patient up. For that reason, several other technologies are available, including ultrasound, which is something that is available at the time of the operation. It's a real-time imaging modality that allows us to assess continuously the operative field. And a lot of times we're able to see the tumor quite nicely on a gross scale, on the scale of several centimeters, and we can monitor that to some degree during surgery. Another tool that is increasingly available but very high cost is intraoperative MRI. And MRI serves as our gold standard clinically. When a patient is brought to the hospital to determine whether they have a brain tumor or not, they often get a CT scan, but that the confirmatory test is an MRI, and that allows us to get a much better idea of what we're dealing with. What is present in a couple of centers is an operating room that's actually outfitted with an MRI. And during my training, I worked with the gentleman who invented this technology at the Brigham back in the late 90s. And we've integrated it into our practice. And NYU, being the only center in New York City that has a functioning intraoperative MRI, is a center where we're utilizing this technology to ensure that we don't leave the operating room until the MRI looks the way that we want it to. So that MRI that we get after surgery is really what serves as the gold standard for how well we've done at taking the tumor out. If we bring that MRI into the operating room, then we can determine at the time of the operation whether we've gotten that tissue out. So we can essentially make sure that we're complete enough in the resection that we intended to take. And so what I've shown here is a case where we used intraoperative MRI to verify that we got the entire tumor out. And a lot of times what will happen is that in the midst of an operation, you think you've reached the end point where you can't see any abnormal tissue around. And then you put the patient into the MRI and you realize, oh, for whatever reason, I didn't recognize there was additional tumor there, I can go back and get that tissue out that contains a lot of tumor and that would have caused deleterious consequences for the patient. And that would be one of those times that I captured in my study where a patient had left the operating room with tumor that could have safely been taken out. So as I mentioned, intraoperative MRI is only present in a limited number of centers. With the large population that we serve in New York, at NYU we have one intraoperative MRI for the population of New York City and the surrounding areas, which means that there are a lot of centers where intraoperative MRI is not available. And there have been a number of other technologies that have emerged, including this one that I show here called 5-ALA, which is a medication that patients can drink the day of surgery, typically a couple hours before. And this medication is consumed orally, as I mentioned, enters the bloodstream and exits the bloodstream within a tumor. And the metabolism within the tumor cells causes this drug to create the accumulation of a pink dye. And under the right lighting conditions, it allows us to see tumor that would otherwise be invisible. And this has been a major breakthrough in our field, pioneered by one of my colleagues and friends, Walter Tumor, who's a German neurosurgeon, Munster right now. And he's devoted his entire life to the development and validation of this dye, which has recently gained FDA approval in the United States. And I would consider it the standard of care for patients who are undergoing surgery specifically for glioblastoma and grade 3 glioma, because it allows us to remove in a more complete way the areas of the brain that are infiltrated by tumor. So very important tool, really should be utilized in the setting of operations for malignant brain tumors. One technology that I'll mention here too is stimulated Raman histology, and this is something that I developed. And as I mentioned, these brain tumors are microscopic phenomena, and it's impossible to be able to see those brain tumor cells with the tools that we have had up to this point in the operating room. We can see the way the tissue looks. We get a idea of overall how abnormal the brain looks, but on a microscopic scale, we're simply guessing. And this is one technology specifically that helps us with that guesswork, because it allows us to differentiate between tumor and normal brain on a microscopic scale. So to demonstrate that, I have an example here of a patient of mine who has a brain tumor, and it's in her frontal lobe. It's the bright tissue just above the nose and nasal cavity. At the time of surgery, when we use the stimulated Raman histology to be able to look at the center of the tumor, we see a pattern that contains many tumor cells. We see the tumor cells spreading amongst the axons, which are the portions of the cells of the brain that are essential for communication. And so we know it's something that's arising from the brain. And then after we've taken that tumor out, we can sample the edges of the cavity, as I showed in a previous slide. And in the operating room, we get this image that shows us whether there are still tumor cells left behind, like we see in the second image I just flashed up, or whether it's clean, whether there are very few cells and the tissue looks more normal. And so this is sort of the extreme in terms of allowing the best resolution, most accurate way of detecting brain tumor cells that ever has been conceived of. And it allows us a level of accuracy in the OR that we previously haven't had. And so instead of getting to the end of the operation and feeling like, oh, well, that looks normal, we can actually verify that and make that decision based on data. So that's sort of a lot of technology, and that stimulated Raman histology is something that's important to me, and I think is something that is emerging, and I'd like to share it with you. And it's a little bit easier to understand if I can share this video with you. So I'm just going to play this. It's pretty short. I'm not sure if the sound's coming through, but I'll just let it go.
It looks good.
Okay, so I hope you get the picture from that video, how we're using this technology. This is a picture of that system in our operating room. And I just put this in towards the end of the presentation to show that we have this sort of a continuum of technologies that allow us to determine whether tissue is clean or whether tumor remains. So whether it's something very basic like ultrasound, frameless stereotaxy, or more sophisticated like intraoperative MRI, or this dye that I mentioned, or even stimulated Raman histology, which is only available in a couple of places at this point. We're working on this armamentarium of technologies that will allow surgeons to get better and better results going forward. And we know that those results translate into better quality of life for our patients and a longer survival. So that is where I will end. I wanted to leave a substantial amount of time as part of this hour for question and answer. I suspect there may be some questions that we don't get to. So I wanted to put my email up. So if anyone has questions, I'm happy to engage over email. And I guess I'll just turn it back over to you, Al, if you want to field questions and we can talk about anything.
Okay, thank you. That was perfect. You could just leave that slide up so people could get that email address.
Sure.
A couple questions. First, with gliolin, does gliolin make an individual cell fluoresce, or is it like your region?
Good question. So what we can see with this image here, this is the same field of view that we would see in the microscope. On the left side of the screen, what you're looking at is kind of what we would expect to see with conventional white light without gliolin. And with gliolin, what we see is that pinkish tissue that corresponds with where the dense tumor is. So it is likely that the way that gliolin causes fluorescence is that this drug is converted in tumor cells to a compound called protoporphyrin 9, which we can see with the microscope. We are not seeing on a microscopic scale an individual tumor cell fluorescing. What we're seeing is a tumor fluorescing. So when we're using this tool, we're looking at tissue fluorescence rather than single cells.
Okay, so it wouldn't make sense to look at using the Raman histology, use the special light for people who had the gliolin. It wouldn't show up, would it?
Yeah, so we actually are looking at that. It's a very good question, and the true answer is a little bit more less straightforward than you might think, because the brain itself also has some fluorescent signal. So when we're looking microscopically, we see fluorescence from the brain, we see fluorescence from the dye, but we're working at ways to sort that out. And there is a really nice synergy of the two technologies that's emerging. So I expect that they will be used in concert moving forward.
Okay, can you say where the Raman histology machine is available? Are you allowed to?
Yeah, sure. We have it at NYU. We're kind of the pioneering site. I developed it at Michigan before I left that institution about a year ago. So it's available at Michigan. It's available at NYU. It's available at Memorial Sloan Kettering. There is a hospital called Hoag Hospital. It's a small private hospital in
California.
Orange County. They've purchased it, and there's a children's hospital in Dayton that has the technology as well. And there are about 4 others that are pretty close to acquiring it too. But until that happens, I wouldn't feel comfortable sharing.
Perfect. Okay, a question about mapping. Do you map every patient?
So the short answer is no. There are some regions of the brain where the neurologic consequences of removing a tumor carry such a low risk that we don't require mapping. I mean, the best kind of mapping is awake mapping. And the most accurate kind of mapping is awake mapping. And generally, our patients prefer to be asleep during their brain tumor operations. So we reserve that best mapping practice, awake mapping, for those cases in which the operation has a risk of compromising language or movement in the patients. And so I would say we probably map about a third to a half of our patients, but a lot of our patients are not don't have to have mapping. And there are some exceptions. If a tumor that comes up to the surface, even if it's in an area that's close to portion of the brain that's important for movement or language, we can still take the tumor out without the need for mapping because we have a way of getting into it.
Okay, before a surgery, how well can you predict what kind of neurological problems will result, or if any will?
With a lot of confidence. I mean, I think that's something that comes with practice. And the other caveat I should provide with this talk is that the technologies I presented are just tools. And really what's the most important thing is having the experience to understand how to deploy them. So a great set of tools in the hands of a surgeon who's not as experienced will not be as valuable as another set of tools in a very experienced surgeon's hands. And what we would want for all of our patients is for them to have very experienced surgeons using all of the available technology. But what usually happens is something sort of in between that. So that's to say that, any one technology really needs to be deployed in the context of the surgeon's comfort with the technology and all of the technologies that are available in the operating room for that given patient.
Okay, can you say about how many brain tumor surgeries are done per year at your hospital?
Yeah, I think we probably do across NYU, we're probably doing about 500 brain tumors per year
Wow.
surgically. And I think there's probably a similar number of gamma knife procedures. So we have a very high volume at our center, and we include several sites in those numbers because NYU is a relatively large organization,
Yes.
and there is a lot of value to seeking care at a center that has high volume and a lot of data that supports the idea that the best outcomes for brain tumor patients are achieved in centers with the highest volume.
Has the COVID epidemic affected those numbers recently?
Yeah, our brain tumor volume has really plummeted. Our operative brain tumor volume is lower than it has been in quite a long time, and that's concerning to us. And there are various explanations that we can speculate about why that might be. Generally, cancer diagnoses are down as much as 30 or 40% right now across the board, not just brain, but in our cancer center, they're down. And that's because patients aren't presenting with the symptoms that would tip us off to the presence of cancer. So I think we're going to see a big bounce back in terms of the numbers. I don't think those patients are going away. I fear that some patients may have passed away during this time who needed urgent intervention. There were certainly some nights in New York City when there were so many sick people that there were probably some of those that were brain tumor patients that um, didn't make it to the hospital for whatever reason. And, and some of our brain tumor patients who had operations during the COVID era, once they were discharged, got COVID. And so I don't know, it's been a very difficult time for our patients, and it's a difficult time for patients who may not know they have brain tumors and are yet to present to our institution.
But you're open, so if people think they have a brain tumor, they should go, correct?
Absolutely. If you have, there are a number of warning signs. I don't know if it would be useful at this point to,
Yes, go ahead.
yeah. So, I mean, the biggest one would be headache that's sort of changed in character. A lot of brain tumors don't present with headache, but the headaches that give us pause for a more malignant etiology are headaches that are present worse in the morning than in the evening, headaches that don't respond well to pain medication, headaches that have changed in character, headaches that arise in a patient who hasn't had headaches before. Those are all red flags and symptoms that you should contact a physician about. Progressive neurologic deficits can be seen, especially in aggressive tumors. So that means difficulty with language, difficulty with cognition. Things are just not seeming to, come out as easily as they were before. Weakness on one side of the body affecting one limb can signal an underlying neurologic process. Those are certainly things that we should be seeing at our hospital. And I think maintaining close contact with your primary care physician about any of those symptoms, and honestly, feeling free to reach out to me if you have any concerns too, via the email that I showed is completely fine too. But I think I would encourage, as you mentioned, patients with any of the symptoms that are concerning to them to reach out to a medical professional.
Okay. Is Gliadel used anymore? It was popular 10 years ago.
So the evidence for gliadel. So what is gliadel? First of all, gliadel is implanted chemotherapy. So it's like a synthetic, what we call a wafer. It's kind of a little disc of almost a paper-like material that we put into the cavity of our patients' heads, into the brain tumor cavity, and the idea is that chemotherapy kind of seeps out of that. There was some published evidence to support its use, and some very reputable surgeons who got behind it and started using it. It hasn't really taken off because the impact of that treatment was somewhat modest. But the idea of local delivery of chemotherapy directly into that area that we've just performed an operation on lives on. And I think that work was pivotal in developing other local therapies for brain tumors. So I don't think that it's used commonly in most clinical practices. And I don't think that, I worry a little bit that when a surgeon uses that they're pitching it to a patient as something that's done as a trial or an experimental treatment. And I think if used in isolation, it's not something that's likely to work, and there is some risk associated with it. So I think it's fallen out of favor a bit, but I think it played an important role in the evolution of local treatment for brain tumors.
Okay. Which clinical trials are you involved with right now?
So there are a number of clinical trials that are open at NYU right now. The most promising of which is a trial of two immunostimulants called ipilimumab and nivolumab. And these agents are immunotherapies that have proven to be helpful for patients with other types of malignancies, other types of tumors. And they're being administered to our patients in the context of their brain tumor care. And there have been some very promising preliminary data that suggests that when we achieve the right combination of immunotherapies, it's possible that we can prolong survival. So I think, as I mentioned in the beginning of this presentation, um, there are a number of clinical trials that are going on right now, and I really think immunotherapy will become a fourth component of the treatment of brain tumors going forward.
Do you think all patients should get a complete genomic test of their tumor sample?
Yeah, I mean, so it's hard to make a blanket statement for all patients, and there are some patients where their quality of life does not justify aggressive treatment, and in those cases, probably detailed genetic analysis for the purpose of modifying treatment is not necessary, and won't really move the needle. From a research perspective, it's good for us to have as much data as possible.
Mhm.
But for most patients who are diagnosed with a brain tumor, I think it's essential that they undergo genetic testing. I mean, first of all, it's important that you bring up this point. So 10 years ago, we were using almost no molecular characterization of brain tumors whatsoever. We just took our brain tumors, looked at them under the microscope, and said, oh, this looks like an astrocytoma, or this looks like oligodendroglioma, and so forth. And now we have a much deeper understanding of the molecular makeup of these tumors that allows us to classify them on a much more reliable and granular way. And so what's been added on to that in the past decade or so is full sequencing of tumors that allow many genes to be analyzed to classify and identify potential therapeutic targets in brain tumors. So I think for most patients, sequencing to allow the identification of therapeutics that wouldn't otherwise be obvious is really important, and it should be done. And it's not just sequencing. So the actual ATGC that make up our genetic code is just a fraction of the picture. And we now know that the way that those base pairs and the DNA is modified specifically through methylation, among other processes, is just as important or more important in being able to classify these tumors. And so having a full molecular analysis of a brain tumor in 2020 now should include methylation analysis. And at this point, it's more useful for a classification, the purpose of classification. But going forward, what we're going to see is an increasingly robust set of treatments that will be associated with various methylation categories of these tumors. So I think although we haven't moved the needle the way that we would have wanted to in terms of survival for brain tumor patients, I think it's coming because we see so much of a greater knowledge amongst our pathologists in how tumors are diagnosed and understood, that the treatments will follow based on that.
Okay. What do you think of freezing the tumor sample for possible future vaccines? That seems to be popular now with a few of them coming close to approval.
I think tumor banking in general is a very good idea, and I would say to patients that I think there is a hope that banked tumor could be used to make a vaccine for that patient. That being said, it's likely that banked tissue will be of research value, and can help with the development of vaccines, immunotherapies, better genetic understanding of the tumors, and so forth. Tumors evolve, though, over time. And so, any vaccine-based approach is likely to require relatively fresh tissue. So the idea that at the time of an index operation, the first time you present with a brain tumor and go and have that operated, to have a piece of that frozen down for characterization as representative of a tumor that may occur in the future probably wouldn't work because the tumor is likely to change. But the idea of tumor-directed vaccines is something that I think has been around for a while and is actually gaining popularity. There's a vaccine-based, sort of intrinsic vaccine-based therapy at Michigan I was involved in developing that has shown some very interesting results in early clinical testing.
Okay. Do you ever use gamma tiles? Do you know what gamma tiles are?
Yeah, so gamma tiles recently FDA approved. So just as we talked about with gliadel, gamma tile is something that you can implant within a tumor cavity that emits radiation. And as I mentioned, radiation is one of the most important parts of treatment of a brain tumor today. And the idea here is that we can implant seeds that emit radiation and kill the brain tumor cells locally. There are some logistic reasons that gamma tile has not been widely accepted amongst our community because we have a vast experience using external radiation sources for the treatment of brain tumors, and the standard of care remains the use of external beam radiation and even incorporating some proton-based methods into the treatment of brain tumors. There is like a tiny amount of data for gamma tile, and it's not nearly as solid as the external beam data is. So I wouldn't recommend gamma tile unless there was no way that you could get conventional treatment via an experienced center. But that does apply to some patients, and the logistics of going to radiation for a glioblastoma patient 5 days a week for 6 weeks can be challenging in some situations. So if the only way that you can get radiation is through gamma tile, then I think it's better than nothing. But I think we're really short on data to suggest that it's equivalent to the standard of care, which we know has proven effects in all types of brain tumors.
Okay. Well, a lot of people are using it for recurrent tumors where you don't usually do external beam, correct?
We will re-irradiate patients in a lot of cases, and the mode of radiation wouldn't dictate whether it could be used or not. So,
Okay. We'll move on. The next question is about the gamma knife.
mhm.
When would you decide to use a gamma knife versus a surgery? First on a glioblastoma, but then on an acoustic neuroma.
Yeah. So there, like with gamma tile, there is there are some situations where gamma knife is more well suited than others, and so to address gamma knife in glioblastoma, one fundamental issue with gamma knife, which is both its strength and weakness, is that it's a very focused treatment, and specifically that energy that does the therapeutic activity in gamma knife has a very tightly prescribed three-dimensional volume. Glioblastoma, as I showed you in one of the earlier slides, the margins of a glioblastoma kind of look like this. And so you can imagine that something that's very well circumscribed wouldn't be the right treatment for a tumor like this, where the boundary is more of a gradient than a very tight margin. It's the pathology. So for that reason, gamma knife has not it's not used as widely in the setting of glioblastoma. It would be used in a situation where a patient couldn't tolerate a repeat operation or didn't want to undergo repeat operation, and their only hope for controlling what appeared to be recurrent tumor was high dose focused radiation, then it might be appropriate. But in practice, we don't do that very often, certainly at our institution. For acoustic neuroma, the pathology is completely different. And the border between tumor and normal structure, and in that case, a facial nerve, is very sharp. And the surrounding structures allow for the targeted delivery of radiation therapy to an acoustic neuroma with great accuracy. In addition, acoustic neuromas sit in an area that's very sensitive to operate on and take an extraordinary degree of expertise and training to do safely. Whereas with gamma knife, the results are quite a bit more reproducible and less dependent on having a superstar surgeon, and they can be quite useful. Generally, we reserve the use of Gamma knife in acoustic neuromas to patients who couldn't otherwise undergo surgery, because surgery can kind of cure an acoustic neuroma, whereas Gamma knife can hold it at bay and in some cases cause it to shrink and be quiescent for a long time. But for younger patients, it's likely that the tumor will come back with time. So when it's possible to do an operation for an acoustic neuroma, we do that operation. If it's not possible for any number of reasons, or if the patient's preference is such that they would rather not undergo surgery, it's possible to do upfront treatment of an acoustic neuroma with Gamma knife. And it's a reasonable treatment, and there's some good data behind it. But it's usually reserved for situations when surgery is not possible.
Okay, you mentioned proton, so let's go back to that. When would you use proton radiation versus standard radiation for glioblastoma?
So I don't, there's some investigations that are currently underway, clinical trials using proton. To back up, the physics of proton beam instead of photon radiation differ in that like Gamma knife, proton radiation falls off. The energy delivered in proton radiation falls off much more sharply at the edges of the treatment volume that you're aiming to address. And so that's very interesting in the brain, where you want to make sure that you're leaving the areas that shouldn't be involved in the radiation treatment plan alone, those functional areas adjacent to a brain tumor. But because of the slide that I have up right now, I don't think there's a huge role for protons in the treatment of gliomas, simply because the volumes that we can craft with photon radiation fall off nicely, probably the way that the tumor cell density does. And so to me, it's unlikely that there is going to be a benefit from delivering a type of radiation that has similar biological effects, but a sharper drop off. The areas in the brain where proton could be very promising are those where we want to try to eliminate delivering radiation to the optic apparatus, for example. So the optic nerves, as they cross in the brain, are sensitive to radiation, and we want to limit any dose and side effects associated with radiation. So in tumors of the skull base, where we're trying to avoid important structures, I can see the utility of using proton beam. And certainly in the spinal cord, in younger patients, where we want to limit the dose of radiation to reproductive organs, for example, in women with spinal cord tumors, where we want to make sure that we're treating just the spinal cord and not the adjacent ovaries, it's reasonable to use proton. And I think proton therapy is one of those treatments that is still emerging, and so we're still learning about it, but the general principles are what I mentioned.
Okay. When do you decide to do a second or third operation for recurrence versus just treating it with other types of therapies?
Yeah, so it's a very individualized and a personal decision for patients that they're faced with on when to operate on a recurrence. So first of all, it can be very difficult to understand in a lot of cases whether we're dealing with what appears to be tumor recurrence versus effective radiation and chemotherapy that they've undergone. So one of the major justifications for reoperating on a brain tumor patient is diagnosis, to be able to understand what we're treating. In some cases, the medical condition of the patient will dictate whether a repeat operation is reasonable and feasible. In other cases, it's the patient's preference. From a surgeon's perspective, we're constantly judging that risk-benefit ratio. And if we feel like we can get a substantial amount of tumor out without causing neurologic problems, without exposing the patient to too great of a medical risk for undergoing a repeat operation, then we commonly will encourage that. And that guideline originates from data in our literature that suggests that patients can safely undergo multiple operations for gliomas, and that the patients who undergo more operations tend to live the longest. And there's some selection bias in those studies, but
Yeah.
In general, we see really good results with reoperations in our patients.
Okay, we're getting close to the end, but a patient asked this very specific question.
Mm-hmm.
She has an inoperable meningioma brain tumor growing on the main vein of the brain.
Mm-hmm.
And she's asked two questions. First, is it better to use a gamma knife while it's still small, or is it safe to just watch it grow and then use it when it gets bigger?
So gamma knife is most effective when tumors are under 3 centimeters, more effective when they're under 2.5 centimeters, and most effective when they're even smaller than that. So specifically when we're intervening with radiation, it's advantageous for that treatment to be delivered early. And so I would encourage patients with recurrent meningioma that's growing, even if it's growing slowly over time, that they should be proactive about getting that treated. And so that is a situation where I do think treatment would make sense, but without knowing all the details, it's hard to make that recommendation.
Okay.
But the take-home point is that gamma knife is most effective for smaller lesions.
Okay, then the second part of the question is, her neurosurgeon is telling her it's inoperable. Should she be getting another opinion to see if it might be operable at a different center?
Yeah. So generally, I think certainly in New York, most patients do get second, third, fourth opinions, and we have great resources in our field that allow for several expert opinions, some of which may differ, some of which would be the same. But I think the best surgeons in competitive markets across the country and across the world are comfortable with their patients getting second opinions. And frankly, I encourage it because I think a patient really needs to feel at ease that they're working with a surgeon they feel like they can connect with best. And that relationship is really important because inevitably this is a really bad disease. And if this patient has in the back of their mind, oh, I don't really like this surgeon, he or she just doesn't really get me or is not available for whatever reason, that's going to be something that bothers them throughout treatment. And you can switch surgeons, but it's best to sort of go with one surgeon that you decide you can have a good you have a good rapport with. So I always encourage my patients to have second opinions and never feel threatened by it, and would encourage people on this call to seek out second opinions too.
Okay, and this is the last question.
Mm-hmm.
Which of the commercial labs do you like the best for evaluation of tumor samples, or do you use your own in-house lab at NYU?
So I'm totally biased here, and I work very closely with the director of molecular pathology at NYU.
Is that
And
Dr. Zagzag?
So Dr. Zagzag is one of them, and Dr. Snooderall
Okay.
is the director of the molecular lab, and they do a spectacular world-class job on tumor analytics. But in the past, I've definitely had experience with a couple of really good private companies that do really nice work as well. So I don't think there's any one correct answer to that question. I think there are great options in academia. There are great options in industry for tumor analysis, and it's really just has to do with the comfort of the treating oncologist.
Okay, that's all for the questions. Thank you very much. It was very informative. I'd just like to talk about next week's event. Next Sunday
Thanks for
is,
having me,
oh,
first of all.
thank you for doing this, especially taking time out on a holiday weekend in
Sure.
the middle of an epidemic.
Mm-hmm.
Next week, we have Advances in GBM Immunotherapy with Dr. Daniela Bada from University of California, Irvine. She's going to be talking about a vaccine that she's working on. Sounds very promising. Should be a good event. See you guys next week, and thanks to everybody. Bye-bye.